Alright, welcome to Road 250. We're going to talk about a few things today, from Giardia to thyroid hormone synthesis. And then we're going to end up with some drugs that relate to thyroid hormone. And so, let's get started with Giardia. So, Giardia is known as something that causes giardiasis, which is bloating and flatulence and foul-smelling fatty diarrhea. And it's often seen in campers and hikers. So, let me ask you a quick question. First of all, what's the transmission?
Fecal-oral.
Fecal-oral.
Fecal-oral, okay, that's correct. But what do you see?
Cysts in the water.
Yeah, cysts in the water. That's going to cause it to transmit. So, I have a life cycle that I'll show you in a few minutes. Or a few seconds, I guess. It won't take that long. So, this is usually campers and hikers who do not purify their waters, and they drink it, and then that causes them to have bloating, flatulence, and foul-smelling fatty diarrhea. So, how do you diagnose this? What can you do? What are you looking for?
Stool test?
Ova and parasite.
Yeah, so
Yeah,
you're looking for the cysts in the stool, or you can look for trophozoites in the stool. And yes, you can do a stool test, or you can do an antigen detection test. And I think from what I've read, and you guys can correct me if I'm wrong, but most of these patients will have vitamin deficiency. Is that correct? Like fat-soluble vitamin deficiency?
Well, I guess it would depend on how long the symptoms last for.
Okay, so I have vitamins A, D, E, and K. They'll be deficient in those vitamins.
Yeah, you have fatty diarrhea, so you're losing those with it.
Right. So yeah, you're not reabsorbing, and the trophozoites don't invade the intestinal wall. So some people may show symptoms, and others will not show symptoms. What is the treatment for giardiasis?
Metro.
Right. So
pretty sure I had this.
You had this?
I'm pretty sure I did in college. We went on a hike and we got thirsty. Let's put it that way.
All right. So before we go, the trophozoites. If you see an image on any of your examinations, it's gonna look like this, and then the cysts will look like this.
Happy little manta ray.
Huh?
It's like a happy little manta ray.
Yeah. Got a little nice little tail to float around in, you know. So you basically ingest it, and they're dormant, and they go through their asexual replication, and not everyone exhibits symptoms, but then they transit towards your colon, and then the cysts and trophozoites are expelled in the feces, and only cysts can survive outside of the host. So cysts can survive for weeks to months in cold water, and then that whole process starts.
Are they assuming that we're pooping on apples?
Well, you're pooping on food, or you're pooping in general, that it gets into food or water.
Is that how you eat your food?
It's a pre-digestion.
You gotta increase your metabolism some way.
I got you.
Whatever it takes.
Remind me not to enjoy your cooking anymore.
As a matter of fact, you enjoyed it all very good. Well,
I did. It kind of looked like that too.
That's messed up. All right. Any questions about Giardia?
Nope.
Simple, easy. All right. So let's talk about thyroid synthesis, and that is the concept for today. So before I click to the next slide and kind of give you guys details, in general, what is the thyroid hormone usually good for?
Increasing and regulating metabolism.
Correct. That's one big one. Does anybody have any other things that they can think of right off the bat when I say thyroid hormone?
Yeah. So yeah, the BMR metabolism, but also like
heart rate,
regulation,
temperature regulation, pretty much
Thermals.
everything except menstruation.
Yeah, menstruation. Yeah.
maintaining homeostasis, cardiac rhythm.
Mm-hmm.
Yes, cardiac rhythm. Essentially, all the manifestations that you get when there is a thyroid hormone pathology.
There you go. That's a good way to put it.
Okay. All right. All right. That's pretty good. All right. So, thyroid hormone is just an iodine-containing hormone that controls the body's metabolic rate, as you all mentioned multiple times. The source is in the follicles of the thyroid, and most T3 formed in target tissues. So what we're going to talk about are just the effects of thyroid hormone. So I'm going to go through certain ones in more detail than others, but we're skipping the bone growth for right now, and CNS maturations. I'll come back to those in a second. So let's start, as you guys said, as a major regulatory of metabolic activity and growth. So starting here, you're also going to increase your carbohydrate metabolism. So that includes your gluconeogenesis and glycogenolysis. You're going to increase your fat metabolism, so increase lipolysis, but you decrease the concentration of cholesterol and triglycerides in the body. You increase your low-density lipoprotein lipases in the liver, so your LDLs will decrease. And you increase the cholesterol secretion in your bile. So that's some of the things that thyroid hormone does there. So if I give you an example of a hypothyroid patient, what would their cholesterol levels be, high or low?
High.
Their cholesterol levels will be high, yes. And if you have a hyperthyroid patient, are they going to have hypoglycemia or hyperglycemia?
High.
Hypo.
Hyperglycemia, because you're breaking it down. Okay, so your basal metabolic rate is controlled again. Let's talk about the heart first. Your heart is controlled by your beta 1 receptors. So what does the beta 1 receptors do in the heart?
Increases inotropy, heart rate, heart contraction, and SA nodal stimulation.
It's going to increase your cardiac output. It's going to increase your heart rate. It's going to increase your stroke volume and contractility. So in a hyperthyroidic patient, you're going to see what?
More of that.
Rate.
Tachycardia, essentially, because of this stimulation. The basic metabolic rate is conducted via what? A specific pump.
Sodium, potassium.
Yep. It's the sodium, potassium, ATPase pump. So the more pump equals the more ATP consumed. So the O2 demand increases to replenish the ATP that you're using. Thus, your respiratory rate increases and body temperature increases. So that's how that works. So in a hyperthyroidic patient, if your pump is working super fast, you're going to have weight loss as a symptom. All right, so thyroid hormones also required for bone growth in CNS, as it's written here. So in a childhood hypothyroidism patient, what would you see?
Stunted growth.
Stunted growth, and you're going to see mental retardation.
Yeah.
So what are some of the causes that you could see hyperthyroidism in a child?
Prednisone. So the mother is taking or is hyper or has hyper or hypothyroidism.
Yeah, I mean, that's possible. I guess that's the biggest thing that I could think of. But some of the other causes of just causing hypothyroidism, which is iodine deficiency, thyroid dysgenesis, and thyroid peroxidase antibodies, or just having a not functioning thyroid peroxidase enzyme is the most common cause. So you want to think of that. So this is the most common treatable cause of mental retardation if you have a thyroid hormone issue. And just just like Lucy mentioned, maternal T3 and T4 crosses the placenta, so that's why it's normal in babies. So that's all I got for that. Any questions? So that's just the normal functions of thyroid hormones, and now we're going to talk about is the synthesis and how this whole process works. So let's start with number one right here. So what is happening here? Your thyroid globulin is synthesized from tyrosine, and in the thyroid follicular epithelial cells, and they're packaged and secreted into the follicular lumen. So that's step one. Step two is when you have an iodine pump or a sodium. Here you can also have an iodine pump or a sodium iodine cotransport, and that's going to be on the thyroid follicular epithelial cells, and it actively transports iodine. So iodine is going to come in, and it basically continues on. So what inhibits this process?
Amiodarone?
I'll talk about amiodarone at the very end of this lecture.
This is excessive iodine?
Okay, so there's something specific. Perchlorate anions are something that will block this process of the sodium and iodine coming inside the cell. And the other thing that I've learned from BRS was thiocyanate. And that's something else that will also block this step. So perchlorate. Sorry, I'm going to try spelling it. And it sucks.
Almost there.
1
One more letter.
I wish I had the pen Pete has. So that's one thing that will block this process. So you can just remember that. They might ask you a question on that. So what is step 3?
The coupling. All right. Yeah. Okay.
No, oxidation is third, and then coupling will come after. Oxidation, organification, and then coupling. So oxidation is when you take iodine as a single molecule and make it a double, so I2. And that's catalyzed by thyroid peroxidase, or the peroxidase enzyme, and I2 is the reactive form, and then this will further contribute with the thyroid globulin that's outside into organification. So the fourth step is organification. So this is where you, at the junction of the follicular cells and the follicular lumen, tyrosine residues of the thyroglobulin react with I2. So your thyroglobulin and tyrosine residues react with I2, and they basically form an MIT or DIT. In this case, in first aid, it shows that this is thyroglobulin with both MIT and DIT. But we'll just use this as an example. So here, this is, Pete, where you're talking about high levels of iodine. High levels of iodine will inhibit this fourth step, organification. Do you know what that is called?
When iodine blocks that step?
So when you have high levels, what is that effect called?
Hypothyroid storm?
No.
No.
Oh,
Like
Wolff-Chaikoff.
radiation?
Wolff-Chaikoff effect. So this is what is going to happen in this effect where you have excess iodine. It temporarily inhibits thyroid peroxidase enzyme and decreases organification, thus blocking everything else after. So you're going to create less T3 and less T4. So just a key to remember there. Okay, so we'll see the next step is coupling, which is also done by thyroid peroxidase. And this is where your MIT and DIT are attached and coupling takes place. So what is T4 represent when you have two of what?
Two
DITs.
DITs,
Right. And what is T3?
an MIT and a DIT.
DIT.
Yeah, one MIT and one DIT is T3, two DITs is T4. What is created more, T4 or T3?
4.
T4, but T3 is the most active.
Correct. That's
Right?
good. Yep. And so in this case, this globulin, or this is what they call iodinated thyroglobulin, they'll stay in the follicular lumen until TSH basically tells it to secrete and stimulate thyroid hormone. So until it requires a hormone, it will stay in this position here as either a T3, T4. So when you stimulate it, what happens? So TSH is basically telling it to stimulate it, and that's step 6. When the thyroid cells are stimulated, iodinated thyroglobulins go back into the follicular epithelial cells via endocytosis, and the lysosomal enzyme digests thyroglobulin, releasing the T3 and T4. So then the leftover DIT and MIT are deionated by thyroid deiodinase enzyme, and I2 is left over and it's reused essentially. So it breaks down into iodine and then it goes back and does the step again. So if you have a deficiency in thyroid deiodinase enzyme, what would it mimic? Yeah. So if you're missing this enzyme, or if this is deficient, it would mimic an I2 deficiency or an iodine deficiency, because it's not.
Oh, because you're not reusing.
You're not reusing it. Yes.
Oh.
So that's a way that you can think about it. All right. So step 7 is when you're basically going to send it out into circulation. So most of the T3 and T4 that are sent out are bound. Do you know what they're bound with? Thyroxine binding globulin. So most of the T3 and T4 are bound by TBG. And we'll talk about certain cases when TBG will be up and down in the next slide. But just keep that in mind, that most of the T3 and T4 out in circulation are bound. They're not free. And finally, last but not least, the last step is when you're going to convert T4 peripherally to T3, and that's done by 5' deiodinase enzyme. So another additional thing that I learned as well was T4 can also be converted to, do you guys know what else it can be converted besides T3?
T3
Reverse
T3.
Yeah, reverse T3. So
It's
this
like
is
the byproduct
um
during T4 to T3 conversion, and then there's like a byproduct which is reverse T3, or no?
I think it's more like a chiral molecule of T3, so it just binds to the wrong site as inactivated.
Inactive.
Yeah. The only reason I kind of learned about reverse T3 was for one disease. You guys know what reverse T3 plays a big factor in? Which disease? Okay, so reverse T3 is an isomer of T3, and it's also derived from T4. So low levels of reverse T3 are parallel with T4. So low T4 equals low T reverse T3. Does that make sense?
Mm-hmm.
Okay, so think about an ill patient who has. So let me see if I can just do a blank screen. What? Okay, I can't clear the screen. So I just cleared the screen. But let's do a patient that has low TSH. Ugh, sorry, guys. And thus has low T3 and T4. So low T3 and T, it does not look like a 3, but T4. Okay, so that will look to you like central hypothyroidism, correct? Low TSH, low T3, and low T4. Now, when in this case you want to check, just to make sure in practice or whatever, the reverse T3 levels. Now, if the reverse T3 levels are low in this patient, then you can stick with your diagnosis of central hypothyroidism. But if the reverse T3 levels are high, what do you consider this patient having? They have euthyroid 6 syndrome. So this is the only clinical manifestation that you need to worry about with reverse T3.
What is it? Euthyroid?
Euthyroid 6 syndrome. So these are patients that look like they have central hypothyroidism, but the only difference in their levels is the reverse T3. So the reverse T3 will always be high in euthyroid 6 syndrome. But in central hypothyroidism, those levels will be down. Yes? No? Maybe?
Is that in first aid?
No. That's something I learned outside of first aid. So,
But good to know because they tend to, like in UWorld, for example, do ask about, like on lab values, what the reverse T3 or T4 levels would be.
Okay.
So wait, is there only a reverse T3? Or can there also be a reverse T4?
no, reverse T3 is converted by T4, so there can't be a reverse T4.
So there can't be, right? Okay.
So it's this to this, but also reverse T3. Just like how Pete mentioned, it's like a chiral carbon.
Yeah.
So that's the additional thing I wanted to add. Any questions about this process? This is blocked because it comes up later. I should have blocked this, but I gave it to you. Any questions? All right. So this slide is basically the slide from first aid, but I just wanted to, some people do better pictures, so I'll just add it in here. I'll come back to this in a second. So T4 is a major product. It's converted to T3 by deiodinase enzyme. And T3 has a greater nuclear receptor with greater affinity than T4. And again, thyroid peroxidase is enzyme responsible for oxidation, organification, and 2-DIT T4, DIT, MIT T3. All this drug stuff will come later. So we'll talk about regulation in a second, but thyroxine binding globulin, TBG, binds most of the T3 and T4 in the blood, so only 3 hormone is active. So when do you see TBG being low?
When there's antibodies against it.
I'm thinking of a specific
hyperthyroidism because it's all being
in patients who have hepatic failure or are taking steroids.
This is a protein.
Right. So your TBG is going to be low. Your total thyroid hormones are also going to be low, but you'll have normal levels of 3 hormone. So just remember that. And when would TBG be high? In what patients?
Pregnant?
Yeah, TBG is high in pregnancy or OCPs. I'm not sure if this will help you guys, but it kind of helped me. But so if you have a rise in TBG, what would happen? So let's talk about the clinical symptoms and what would happen. What would be T4? Would that be more bound T4 or more free T4?
You got more free.
You're going to have more bound because it binds TBG. If it's high, you're going to have more T4 that's bound.
Okay.
So this will cause increase in bound T4. and that will be means you have less free T4. I'll just put a B for bound. So you have less decreased T4 that's free. That's the free. So what in the end it will increase your TSH to make more T4. So your total T4 will increase again because you're increasing TSH. So total T4 goes high. And then your free T4 will fall or increase in free T4, so it will make the TSH go back to normal, and then that will basically cause the TSH to drop. So women who are pregnant and taking OCPs in settings of normal free T4 and normal TSH level will have a high total T4 count. So that's kind of like the mechanism that I think about. Any questions? This is the Wolff-Chaikoff effect. Excess iodine temporarily inhibits thyroid peroxidase. So you decrease your organification and thus your production. Okay, so moving forward, we're going to talk about thyroid regulation real fast. So this picture is very well, it makes perfect sense, but in words, your TRH is secreted by your hypothalamus to stimulate your TSH by the anterior pituitary, which TSH will then increase the synthesis and secretion of thyroid hormone by the follicular cells, as we talked about, and that's via the adenyl cyclase CMP mechanism. So if you get a question about how that second messenger system is, it's adenyl cyclase CMP. And then T3 downregulates TRH, as you see here, and also in the hypothalamus and anterior pituitary. So this is the other one, thyroid stimulating immunoglobulins. So they're components of IgG, fraction of plasma proteins, or antibodies to the TSH receptors on the thyroid gland. So these bind to TSH receptors and basically act like TSH receptors, so it secretes T3 and T4. So when you see a high circulating levels in patients with Graves' disease, you'll see a high thyroid stimulating immunoglobulin. So that's another thing that you want to think about. So, any questions? All right, so just generally, what are the symptoms of hypothyroidism? And then quickly just give me the lab findings, and that's it for this slide. Again, this is
tolerance, weight gain, decreased appetite.
Okay.
Bradycardia.
Correct. How's their skin?
Dry.
Mm-hmm. How about reflexes?
Hypo.
Slow.
Reflexia, yeah. How about GI motility?
Reduced.
Decreased.
Yeah, so,
Constipated.
kind of. So it's cold intolerance, weight gain, decrease in appetite, hypoactivity, you feel tired, fatigued, depressed, are constipated, decrease in reflexes. Mixed edema, that's for pathology that somebody can cover at a later date. Dry, cool skin, and bradycardia. How about lab findings? What would you see?
Low T3
Low
and T4.
T4.
Low T3 and T4.
So high TSH maybe?
Yeah, high TSH, low T3, T4, and then hypercholesterolemia due to decreased LDL receptor expression. And hyperthyroidism, everything is opposite. So I'm not even going to ask you. Eat intolerance, weight loss, increase in appetite, hyperactivity. They have diarrhea. Again, pretibial mixed edema and Graves or periorbital edema. Have a warm, moist skin. and then you're going to get chest pain, palpitations, and arrhythmias. And how about lab values for this one?
High T3
High
and
T3,
T4.
T4.
Low TSH, low cholesterol.
Hypocholesterol due to LDL receptor hyperactivity. Cool. Any questions?
Always forget about that cholesterol thing.
That's good to keep in mind, I guess.
Yeah.
Always good to remember. All right, so thioamides or amides.
Thioamides.
Amides. I thought I had it right. I screwed up. All right, so what are some thioamides?
ETU and methimazole.
Methimazole.
What is their mechanism?
A
Um,
block thyroid peroxidase.
Blocks thyroid peroxidase. So which steps will it inhibit?
Iodination,
organification, and coupling.
organification, and peripheral
Yeah, exchange of
um,
2,4,2,2,3.
By blocking which enzyme?
5' deiodinase.
Deodonis.
5 prime. Yeah, she said that.
All right, so when do you give this to a patient?
Hyperthyroidism, great.
Yep, hyperthyroidism. And PTU is given in the first trimester of pregnancy because of methimazol's teratogenicity. And methimazole is given in second and third because of PTU's hepatotoxicity. So I gave you some of the ADRs. Can you guys give me some others?
Neutropenia.
Okay. What kind of anemia would it cause?
Yeah.
Aplastic anemia. So skin rash, aplastic anemia, hepatotoxic. Rarely it's seen as agranulocytosis. And then neutropenia is also another one which I just didn't add. And methimazole is a teratogen. Aplasia cutis is what, so fetal scalp defect in a patient. Yeah. So let's talk about the other set of drugs, which is this levothyroxine and hypothyroidism.
So these are analogs of thyroid hormones.
So they're hormone replacement drugs. Clinical uses.
Hypothyroidism.
Yep.
Hashimoto's.
Yep, and that can also be used as weight loss supplements, which probably shouldn't do. Yeah, it's probably the worst thing you can do, but
Off-label.
it's there. They probably could ask you just to be, and then adverse effects. So that's supposed to say adverse effects, so I screwed up. But tachycardia, heat intolerance, tremors, and arrhythmias. And just as a quick fact slide, amiodarone, I always talk about amiodarone when I ask you guys questions about this, but amiodarone can either cause hypothyroidism or hyperthyroidism, because either it can cause hypothyroidism due to the iodine excess, because amiodarone does have iodine in it, and that's due to the Wolff-Chaikoff effect, or it also has been shown to inhibit the 5' deiodinase enzyme, which basically blocks the conversion of T4 to T3. So that's causing hypothyroidism. And in hyperthyroidism, it's due to the increased iodine load, and obviously it just doesn't go through this, and it still continues, or thyroiditis. So it's always good, and amiodarone's always, it shows in first aid that you're supposed to check your thyroid levels as far as, and your liver function tests. So this is why, essentially, because it can have an effect in both hyper and hypothyroid.
And pulmonary function tests.
And pulmonary function tests, yes. Those three things are major things that you want to check with amiodarone. So I have one question for you guys. A 58-year-old woman with hyperthyroidism is treated with PTU. The drug reduces the synthesis of thyroid hormones because it inhibits oxidation of what? Simple, hopefully. Iodine.
Yeah, iodine.
Organification. Sorry, it was on the spot. I had to find the question. So it inhibits peroxidation, therefore it halts the synthesis of thyroid hormone. And if nobody has any questions, that will be the end of today's PowerPoint.
Well, here, I'll share the screen really quickly to add in. Tulsi, this is a representation of the T3, T4, and then reverse T3. So, like he was saying, it's just he used the right word, an isomer. I used the wrong word, but an isomer, just meaning that the number of iodine molecules is the same in T3 and reverse T3. It's just it's in the wrong position. So here, this positioning does not let it be active, and it's just kind of just a free floating molecule. Whereas here, this is the anyway. This is what I was trying to show. So you have an isomer, a T3 and reverse T3. That it's the same number of iodine molecules. They're just in a different position, which will render one to be worthless and the other to be active.
Okay, I see that.
So that's it. Yeah.